مساء الخير. نبيل محمد أحمد، أستاذ أورام في جامعة بيلر. أشكر المنظمين أنهم دعوتي. Today I'll be talking about CAR T-cell therapies in pediatric brain tumors. I'm a member of the Center for Cell and Gene Therapy, a specialized center for genetic engineering of T-cells and therapy. These are my disclosures. I served in the past on advisory boards, received royalties for inventions from companies, and continue to consult for the Children's Cancer Hospital of Egypt. I would like to discuss with you chimeric antigen receptors. I will analyze with you some preclinical and clinical trial results and share with you how this guided future developments in the three areas seen on the screen. In 1859, two gentlemen in rural Pennsylvania were able to drill a hole into the depths of Mother Earth, and they brought out the complexity of a liquid that has been there for thousands of years. Similarly, two gentlemen also in the Weizmann Institute in 1989 were able to join the antigen recognition domain of a monoclonal antibody to a signaling domain from a T-cell receptor. And by doing this, they harnessed the killing power, the distinct specificity, and ability to move of a T-cell. And this cell got the name of CAR T-cell based on the name of the molecule they described, chimeric antigen receptor. CAR T-cells have been quite successful, and a core advantage of these cells is their freedom to operate. So if you look to the right side, this is how a traditional T-cell is able to recognize its target. For this to happen, the tumor target here in yellow triangles has to be taken up by the tumor, broken down in proteasomes into small immune units or immune recognizable units, and then presented on the surface in the context of MHC in cancer, typically class 1. This typically fails in cancer, and therefore the immune cells can infiltrate the tumor, but are often unable to recognize and kill the tumor. If you compare this to the operations of chimeric antigen receptors, these cells recognize intact molecules, typically on the surface, and including non-protein molecules on the surface of the cancer cell. And by doing this, they overcome the restrictions that have been imposed by the MHC class 1 molecules. In addition to this being specific, having favorable kinetics of T cells and alternative killing mechanisms that the tumor cells are not necessarily or typically immune to, core discipline is the HLA independence, as I described in the last slide. The manufacture of CAR T cells is fairly simple. Cells are taken from the peripheral blood of the patients by a blood draw, typically, and they are activated using cytokines, and the most recent uses IL-7 and IL-15. Once they get activated, an encoding DNA of the chimeric antigen receptor is introduced using a viral system where the T-cell products then express chimeric antigen receptors for the life and for the life of their daughters. So this is a stable expression of this chimeric antigen receptor. We have been very interested in this line for several years, specifically in the early 2000s. We collaborated with an eminent scientist in Frankfurt, Germany, Georg Speierhaus, and Dr. Stefan Gottschalk and I led some studies creating a chimeric antigen receptor that is described here on the slide. This chimeric antigen receptor targeted a cancer antigen that is famous in breast cancer called HER2, or human epidermal growth factor receptor number 2, using an antibody described by Winfried Wells called FRP5, We used the variable light and heavy chains from this antibody to create an extracellular domain that can recognize a target. Typical of the prototype chimeric antigen receptor, we put a zeta chain, which is from the T-cell receptor and can initiate signaling. We made a second generation receptor that includes a 28 signaling domain, creating a second generation or a more advanced than the prototype. Later on, with other colleagues, we established several studies. First of these showed that you can kill tumor cells taken from patients, in this case glioblastoma, and you can also kill the stem cells from this or the progenitors within these tumors using the patient's own HER2 chimeric antigen receptor T cells. We expanded this work, as shown here in these reports, in several brain tumors, including medioblastoma, glioblastoma, ependymoma, typical of children and adults, respectively. We tested also on osteosarcoma, Ewing sarcoma, and lung metastatic tumors as well. And out of this came a series of trials for osteosarcoma and other sarcomas, as shown here, HEROES 2.0. And I focus today on brain tumor trials, of which HER-GBM, ICAR, and ICAR Junior, and hopefully in the near future, HER-ependymoma is another trial. These are the mnemonics we give them, as I'll show you later on. The first trial we conducted in brain tumors that included children and adults was HER-GBM. This clinical test was done in 17 subjects. 7 of these were children. We used a design called the MCRM, or Modified Continuous Reassessment Method, in which we give the patients incremental doses of CAR T cells intravenously. 1 million cells per meter square, 3 million cells per meter square, going up to 100 million cells per meter square. We included 3 patients on each cohort. And since this is continuous reassessment method, we go back and assess for the toxicity with every increase that happens every 6 weeks. We haven't seen any on this study that is already published, as shown to the right-hand side of the screen. We haven't seen any severe adverse events that stopped us from increment, and we achieved the highest dose level. What we saw was quite interesting, that independent of the dose level, the cells after infusion, these are days, tend to increase and then decrease, and were detectable only up to 6 weeks. So this is one lesson we learned. The second lesson is we were able to demonstrate some clinical efficacy. Shown here, 1 patient achieved a partial response, 7 patients achieved stable disease that was up to 34 months. Half of the patients roughly progressed. Shown here is a patient, a 17-year-old boy with thalamic unresectable glioblastoma that shrunk with 1 dose. This was durable for 10 months, and then he progressed afterwards. An older female who had a relatively small tumor that looked like it increased. We typically saw this brain edema after infusion. This lasted more than 24 months in stable disease. Eventually, she progressed at 34 months. Another 15-year-old girl with a massive tumor on the frontal lobe, frontoparietal lobe, frontotemporal lobe, and also increased after we gave the cells, and this lasted for about progressive disease. What we learned here is that the increase is an increase in edema that was not associated with increase in the tumor mass. So when we analyze the swimmer plots here, we'll find that interestingly, the survival following progressive disease was quite remarkable in these patients, which prompted us to tolerate brain edema, as was shown also by other studies. I'll show you here. This is a survival curve of patients who came to us without prior salvage therapy. And you can see here, quite interesting despite the small numbers of patients. There was a trial that was also described from University of Pennsylvania, giving a single dose of EGFR V3 directed CAR T cells. And I discussed this trial because it is very reminiscent of what we've experienced was. The trial gave this dose of cells to 10 adults with refractory or recurrent GBM, glioblastomas. They similarly found limited durability in the peripheral blood, found no severe adverse events or cytokine release syndromes, had one patient with stable disease, and interestingly and more than what we've shown, they found that the cells can traffic in 5 out of 7 tumors, and interestingly in these tumors, they found both tumor heterogeneity of the antigen, but very interestingly antigen loss. And this was actionable because later on our studies have focused on this antigen heterogeneity and antigen loss. Moreover, they found a very impressive amount of inhibitory molecules in cells, as I will show later on. MRI findings I'll share in the next slide, but for now, this is the survival of cells, and I hope you would agree with me that if you look here, this is a 20-day scale, so perhaps 30-day scale here altogether. Cells go up and they go down independent of the dose, so very limited longevity of these cells. These are the scans, the MRI scans from these studies. I hope you can appreciate that similar to our study at Baylor, these patients also had massive increase in the edema around the tumor that looked like progression. Nevertheless, it was pseudo-progression. These patients went to do better than the scans showed, and on subsequent studies, we continue to give T cells despite this massive edema that we saw. Similarly, a swimmer's plot, similar to the one I showed from our study, shows that you can have some durability after the patient is taken off of the study. There was one patient, it was interesting, published in New England Journal of Medicine from City of Hope, an adult with multifocal refractory GBM, received CAR T cells that are directed interleukin-13 receptor alpha 2, and had a durability of 220 days, which was quite impressive. This patient received intracavitary and intraventricular T cells. Cytokines were found in both, in the CSF mostly, and no severe adverse events were seen. You can appreciate here how the scheme of treatment is extremely intense, given from intratumorally through an Ommaya reservoir, a Rickham catheter, and given through the CSF and peripherally. This patient had a regression of all intracranial and spinal tumor for 7.5 months, an isolated but nonetheless impressive response. So if we collect what we've learned so far from these clinical trials, the achievements have been that some targets have been established, like HER2, IL-13 receptor alpha 2, EGFR-V3, but perhaps the profile of these targets that seem to be very evanescent and changing with time is very important. GD2 was brought in diffuse intrinsic pontine glioma, as described from Stanford. Our colleague Pietro Dotti published on CSPG4 in glioblastoma, and this is being pursued clinically. We knew that there is some homing, but maybe this is inadequate. We found some toxicity profile that is quite favorable, but in the context of lack of efficacy, perhaps this toxicity profile needs to be re-evaluated with appropriate survival of the cells and expansion. Lastly, we saw some efficacy. We questioned the presence of edema, and we started using a modified version of the IRANO criteria, in which immunotherapeutics were seen to cause tumor edema, but this did not indicate tumor progression. A lot of these were actionable. The challenges that we face now were that the tumor is heterogeneous, there is antigen escape. Poor CAR T cell expansion and persistence is another avenue that we work on. Lastly, the hostile tumor microenvironment. Our group has also been addressing this. Antigen heterogeneity, the earliest studies were published by my colleague in my lab, Mina Hegde, who's now a prominent clinical trialist and preclinical researcher. Mina has done this experiment where she used HER2 CAR T cells to treat a HER2 IL-13 receptor alpha 2 double positive tumor, and found that with time HER2 is lost, but IL-13 receptor alpha 2 is not lost. She repeated the same experiment in animals, in mice, experimental mice, found that when we target HER2, HER2 is lost. When you target IL-13 receptor alpha 2, IL-13 receptor alpha 2 is lost. Hence, we developed the concept that antigen heterogeneity exists. Following this, our colleagues Brown et al. In City of Hope also described this preclinically with IL-13 receptor alpha 2, clinically, and the paper I showed, the report I showed early on from UPenn by O'Rourke and Marcella Mouse's group showed that EGFRV3 also tends to be lost in these patients after treatment when the tumors are taken out. So antigen heterogeneity is reality. So we spearhead efforts to pool CAR products, target 1 here shown in blue, target 2 shown in red, and we found that you can offset this antigen escape when you just simply pool them, and we call this, nicknamed it CAR pool. If you graft an individual cell with more than 1 CAR, and we went up to 3 CARs on the individual cells, both in glioblastoma and in leukemia, we found that you enhance the T cell activation. Later on, we designed this molecule that I'll talk about a little bit later called the tandem CAR. It is one molecule that can see 2 targets simultaneously. From the bi-CAR logic, this is the concept where you put more than 1 CAR molecule on a single T cell. Different logic gates can be employed. You can simply have cells that can target 1 or 2 by simply putting 2 complete CARs on one single cell. You can have a conditional gate wherein the T cell will only target 1 and 2 when both of them are present. For instance, when you have a target that is shared with normal body tissues, but another target that is only tumor specific, these cells will have a complete signal only when both of them are present. Sometimes when the antigen is shared with normal tissues, we can put a CAR for a normal tissue antigen. In this case, the CAR for the normal tissue antigen is a negative CAR. So if it is seen here, it vetoes the activity of the T cells. And very interesting work from the west coast of the United States in UCSF has described a CAR system that is controllable by small molecules. So the engineering is very robust, and there has been quite a bit of improvement in the CAR designs. From our group, from our lab, Mina and Zakaria Grada described together a molecule that can target both antigen 1 and antigen 2 together, and we showed that these can bring both targets together, as shown on this conditional assay. And when you do these experiments in animals, these have a much better, significantly better activity against tumors that are positive for both targets. This again is called TAN-CAR or tandem CAR. The expansion and persistence was the second problem, as I showed you before. In the HEROES trial, we found that the cells do not survive long enough, as shown here. But when we were able to lymphodeplete the patient, this is a patient that is a rhabdomyosarcoma patient, we were able to get a complete response. So having to achieved this increase in the tumor, in the T cell presence in the blood, definitely achieves a threshold that seems to dictate some better efficacy than what we saw before. This is the patient's tumor in the bone marrow before the treatment and then after the treatment. Fortunately, we found HER2 expression to be present in ependymoma. This is work done with Michael Taylor and Laura Donovan in Toronto and published recently. This led us to create a trial with the Pediatric Brain Tumor Consortium called HER-Ependymoma. And in this trial, we're conditioning the patients in 3 dose levels. So we're giving them a lymphodepleting regimen before giving the HER2 CAR T cells almost in an auto-transplant fashion. We're hoping that this will be open in the next 6 months. Another strategy is to give the cells intracranially. I will skip this for now for favor of the time. The tumor microenvironment tends to be quite hostile. We find here PD-1 expression, PD-L1 expression in tumors and in T cells, respectively. And this has resulted in quite a bit of resistance shown here in the clinical trial from UPenn, together with the expression of inhibitory cells, and that increases after treatment. So in our lab, we've used another engineering strategy to change the PD-1, PD-L1 from an inhibitory signal, as shown here, into an activatory signal. These are the constructs we use. You can express the CAR and the PD fusion molecule. As you can see here, in animal studies, the cells that express the HER2 CAR and the PD inhibitory reversal molecule tend to do much better. In summary, I've shown you that CAR T cells demonstrate promising anti-tumor activity. Efficacy challenges are tumor heterogeneity and antigen modulation, inadequate T cell kinetics, and microenvironment inhibition. This serves as a platform for rational cell engineering and our clinical trial setup, hoping to lead to sustained, meaningful responses. At the end, I would like to thank my esteemed colleagues, as well as the funding agencies listed on the screen. Thank you very much for your attention.